All right, let's dive into a case that feels like it was ripped straight out of a neurology textbook. We're talking about a story of sudden, catastrophic paralysis that points to one very, very obvious diagnosis. But, as we're about to see, the most obvious answer isn't always the right one. This is a true masterclass in looking beyond the classic presentation.
All right, so let's build this case together, just like the clinical team did on the ground. You're about to see how every single piece of initial data points towards one very specific, very serious diagnosis.
Okay, so our patient is 24, and up until just a couple of months ago, she was perfectly healthy. No significant past medical history. This is what makes the whole thing so alarming, right? This acute, sudden weakness in someone so young and healthy. Now, the timeline here is just textbook. You've got this classic trigger, an episode of gastroenteritis about 3 weeks prior, and then, like clockwork, a weakness starts in her legs and just marches its way up her body. I mean, it's that perfect ascending pattern we were all taught to recognize. And then you get to the physical exam, and it feels like you're just sealing the deal. She has this flaccid paralysis with generalized hypotonia. She's having trouble swallowing. Her neck muscles are so weak she has a head drop. And this is key. Her sensation is totally intact. It's a pure lower motor neuron picture through and through.
So with this mountain of evidence, the team moves forward. They're confident in their working diagnosis, and they immediately start the standard of care for what they believe is a life-threatening condition.
And that diagnosis is, of course, Guillain-Barré Syndrome. It just fits perfectly. Post-infectious trigger? Check. Ascending symmetric flaccid paralysis? Check. At this point, you would be really hard-pressed to argue for anything else.
And to top it all off, even the electrodiagnostic studies, the EMG and nerve conduction studies, they come back supportive. They're showing a mild axonal neuropathy, which is totally consistent with certain variants of GBS. Every single piece of the puzzle seems to fit. So she's admitted straight to the neuro ICU. They start plasmapheresis immediately. And you know what? There's even some partial improvement after each session. The treatment seems to be working, which feels like it's just further confirming the diagnosis. But things are about to take a very sharp turn.
You see, amidst this whole seemingly straightforward case, the team ran a full electrolyte panel. And one number came back that just didn't make any sense at all.
2.0, a serum potassium of 2.0. Let that sink in for a second. This is a critically, life-threateningly low level, and this one number is the loose thread that, when pulled, is going to unravel the entire GBS diagnosis.
The crucial thing to understand here is that this wasn't just a minor dip. This was a profound, refractory hypokalemia. I mean, they were pouring potassium into her. We're talking up to 12 IV ampules a day, and her level just would not budge. This wasn't a side effect of something, this was the main event. And this is the million-dollar question. This is the question that forces a complete diagnostic reevaluation. How does severe, stubborn hypokalemia fit into the picture of GBS? Well, the short answer is, it doesn't. It doesn't fit at all. Something else has to be going on. So that one anomalous lab value forces a complete pivot. The investigation now shifts entirely away from the nervous system and starts following the trail of the real culprit, the endocrine system. And this slide just brilliantly illustrates that diagnostic pivot. The thinking goes from what's wrong with the nerves to why is she wasting so much potassium? And the prime suspect for profound renal potassium wasting? That's right, an excess of mineralocorticoids, which leads right to the hypothesis of primary hyperaldosteronism.
So this now becomes the leading diagnosis, Conn's syndrome, a condition where the adrenal glands are just pumping out way too much aldosterone. This makes the body hold on to sodium and water and waste massive amounts of potassium. And what does severe hypokalemia cause? Paralysis. Suddenly, it all starts to make sense.
So, with this strong new hypothesis, there was one definitive test left to do. They had to get an image of the adrenal glands to see if they could find the source of all that excess aldosterone.
And that CT scan, it didn't just provide a diagnosis, it revealed the direct path to a complete and total cure.
And there it was, a benign tumor, an adenoma, sitting right there on one of the adrenal glands. This was the source of everything, the hypertension, the crazy refractory hypokalemia, and that devastating paralysis. The patient then underwent a laparoscopic adrenalectomy to get that tumor out, and the result was, well, it was nothing short of miraculous. I mean, look at this table. Her blood pressure normalized completely.
Her potassium shot back up to normal without a single supplement. And the paralysis? Gone. Completely resolved. She was cured. So what are the absolutely crucial clinical pearls we can take away from this incredible diagnostic journey?
Dr. El-Alfy really summarized it perfectly. This wasn't a strange case of GBS. This was a classic endocrine disease that was presenting as a perfect neurological mimic.
First, always check electrolytes in any patient with acute flaccid paralysis. It doesn't matter how classic the presentation looks. Second, primary aldosteronism, or Conn syndrome, absolutely has to be on your differential for GBS mimics. Third, this case is a perfect example of how a common trigger like gastroenteritis, which causes potassium loss on its own, can push a patient with an underlying endocrine disorder right over the edge. And finally, refractory hypokalemia isn't just a symptom to be managed. It is a major red flag that screams, "Look deeper." It demands an extensive workup.
This case is such a powerful reminder that even when a patient perfectly fits a textbook description, we have to stay curious. We have to stay critical. It really pushes us to ask, what other classic presentations might be masking a completely different underlying cause? And that's a question worth considering on every single round.